Hi, everybody. Welcome, everyone, and thank you for joining us today. We have a great topic today, and I'm really excited to have Dr. Shah and Dr. Pham joining us to help us discuss how pediatrics, PT, and PM&R can work together to help a child develop and grow. So first, I want to introduce our two special guests. So we have Dr. Shah joining us today from Ashburn Pediatrics. She joined Ashburn Pediatrics in August of 2007 after completing her pediatric internship and residency at Children's National Medical Center in Washington, D.C. She attended medical school at University of South Florida in Tampa, and she's board certified by the American Academy of Pediatrics. She chose to practice primary care because she enjoys preventative medicine, and her special interests include working with adolescents and treating asthmatic patients. Dr. Shah lives with her husband, 3 girls, and dog in Ashburn, Virginia.
2 dogs now.
Welcome. We're so glad to have you. And Dr. Pham is new to the Washington, D.C. area. She is just opened a new clinic, Reach Pediatric Rehab, which provides rehabilitation medicine services to children with disabilities and adults with childhood onset disabilities. Dr. Shah completed her medical education at Georgetown University. She did her residency at Johns Hopkins and fellowship at the Pediatric Rehabilitation Medicine at Seattle Children's Hospital. She stayed on as faculty there for over 5 years, and she recently moved back to the area with her husband and son. So welcome, we're very happy to have you. And I am Leah Kenya. I am a pediatric physical therapist at the Children's Therapy Center in Falls Church. So I wanted to talk today about how pediatrics, PT, and physical medicine all kind of work together and how we can help our children develop and grow and get on the right track as they're achieving and attempting to achieve their milestones. So Dr. Shah, I wanted to kind of open our discussion with you. So when our families typically have concerns, the first person they go to is their pediatrician. What do you screen for when a child goes to their well check? And what are some things that you might be looking for, some red flags that you might see when a child's coming in and they may not be meeting everything that they should be for their age?
Yeah, so first of all, just, like you mentioned, I'm really interested in general pediatrics because of my interest in preventative care. So we basically see our patients, our little kids on routine intervals for several reasons. A major reason is so that we can do preventative care like vaccinations and give anticipatory guidance about, disease prevention and things like that. But there's also real reason that we're doing these routine visits is to assess development on routine intervals. And there's basically some well-defined developmental milestones that we're looking for at each given age that children are coming in for their physical. So 2 months, 4 months, 6 months. We're looking for kids to meet certain milestones in different areas of development. And we're basically looking at 5 general areas of development: gross motor development, which is kind of more what we're going to be focusing on here today in this talk, but also fine motor. So gross motor would be the more big muscle groups that lead to crawling, walking, eventual running and movement. And fine motor development, that's more of the smaller movements that lead to dressing and feeding and, using your hands basically is a big one. But we're also looking at all other areas of development too, like communication, problem solving, and social and emotional development. And they all we're assessing all of those things all at once. We use at our practice, so first off, we always ask parents if they have any concerns, because parents know their kids best, and we want to hear, if a parent has a concern about their kid, whether it might be something that's truly a concern for us or not, we want to hear what the parent is thinking and feeling about what they're seeing with their friends' kids and whatever. So we ask that question at every visit. Do you have any concerns? Do you have any specifically developmental concerns? We also try to get, we use a parent questionnaire called the ASQ3, which is the Ages and Stages questionnaire. And it's basically has a series of 6 questions per different area of development that I mentioned before. And we're just basically asking parents to look at their, we email the questionnaires to parents about a week prior to the visit, and they're supposed to fill them out while watching their kid, maybe try out some of the things on the questionnaire and send them back to us. And then ideally, in an ideal world, we have the results before we go into the room with the kid. So we have any parent concerns that come up on that as well to address. And that's a nice way for parents who are not sure if they have concerns to kind of bring them up in a less, they don't have to actually talk about it as much kind of a way. It's also makes it allows it to be a little bit more objective. And so we like that to assess things a little bit more objectively. You get a score for each area of development. And then basically what I look at is if I have a kid who's scoring in the pass zone for all of the areas, then I sort of think, okay, well, we don't have that much to worry about in this kid. If I have a kid who's failing some of the sections, I basically ask more directed questions based on those results. So that'll make it a little bit more directed because we really don't have too much time in each of these visits, unfortunately. We also then will ask, we'll obviously do an exam of the kid. And during that, we're kind of looking at how the kid interacts with the parents, how they move around the room, how we're listening for, any kind of expressive communication, we're watching for nonverbal cues and things like that. And then we're checking them on their physical exam, checking for muscle tone, strength, and asymmetry in their left and right sides. We're looking for all of those things. We're looking at how if they have a neck tilt or any kind of, basically we're looking at the whole picture for the kid with the exam as well. We're also just kind of looking for progress. So, if we have a kid who's not really progressing in an area of development, obviously that would be a red flag. If we have a kid who's progressing but on a slower path, we may think that's okay. So it kind of depends on the situation. What else? For red flag kind of stuff. I think you're wanting more gross motor sort of red flags. Obviously, we're looking at red for everything. So it's a lot that's going into these visits. But for gross motor, we think of the big movement kind of, walking, crawling, sitting up. And so those are like the big things, but there's a lot of little things along the way in the earlier part of a child's development that we're also looking at. So can they, hold their heads up when they're in tummy time by the age of 2 months? So can they put their head up a little bit? Can they sit unsupported by 9 months? Can they crawl or at least try to move from like point A to point B by around 9 months? And then can they walk by 18 months? If they're not meeting those milestones, then we know that we have an issue that we need to refer to early intervention for. We also just do a lot of just anticipatory, like preventative kind of things, like we're encouraging gross motor development by making sure parents are putting their kids in tummy time. Putting their kids down on the floor is a big thing, not always holding them. Putting them on the floor instead of equipment like exercisers and jumperoos and bumbo seats and all those things. So actually having floor time to help develop those muscles, and then repositioning their heads if you notice a head tilt and flattening of the head. And yeah, that's pretty much what we're looking for at these well visits. So
yeah, no, and that's great, because I feel like when we have a family that's referred to us, usually directly from the pediatrician, we're doing a lot of that same education too. So it's good to know that the family is receiving that education on both ends. And then, when we have a family come to us, you kind of pinpointed to one area that we also look for too, which is progress. So a lot of times we might initiate therapy. Maybe the doctor was on the fence on whether they needed services or not, and the child is presenting with enough of a delay for us to initiate service. But we'll look for progress as well. And if we're not seeing that progress, that's when we're reaching back out to the pediatrician and I'm wondering, who should we pull in next? Where should we take this family and guide them to see if there is any more going on that maybe is, just not on the surface. And that's where I feel like our specialties come in. So Dr. Pham, can you tell us a little bit about what physical medicine and rehab is? I feel like that's always the first question a family asks us is, what do they do?
Yeah, absolutely. So I like to tell people that I'm the doctor of function. And so my goal for a child is for them to be as functional as possible. And for every child, that's different depending on what their underlying disorder is, if there is one. And so that's different for a child who has very high functioning CP compared to a child who maybe is more at a wheelchair level. So the goals and what that looks like may be different. So ease of care and comfort is also a goal for patients who maybe have different functional or different gross motor goals. So those are some of the things that I do as a rehab doctor. What that actually looks like is sometimes diagnosing a disorder. So I primarily work with children who have cerebral palsy, mainly because that's the number one motor disability of childhood. And so for a child who maybe initially has one of those red flags in terms of development. And just to kind of add to that, some of the ones that I look for are early hand dominance, asymmetric crawling, things like early head control, which some parents are like, oh, their head control is great. And actually, sometimes that's not a good thing. Sometimes that's an indication that a child has high muscle tone or hypertonicity. So, it starts with the identification, and then they eventually get either through a PT or directly to me as a rehab doctor, and I start the process for diagnosis, and then offer therapies and different interventions for treatment. And so that may mean referral for different types of therapies. It may mean medication for muscle tone. If muscle tone is high, it may mean bracing, like orthotics for the foot and ankle, or the upper extremity, the arms, hands, wrists as well. And it may also look like equipment, whether that's mobility equipment like a walker, wheelchair, or also technology for communication, so communication devices. And I have a lot of experience and expertise as it pertains to the functional sort of goals and functional prognosis, especially in the population of children who have CP, because we have the most research on that population. So one of my really big goals is providing education. Where is my child now? Where are they going to be when they're 4, 6, 10, 18? What will that look like from a functional standpoint? And depending on a child's diagnosis, that's something that I'm able to provide as well. For example, if a child has only one side of their body that is affected, that is a child generally that's going to walk. And I can tell you that before they're even anywhere near walking. There are certain sort of motor milestones that we have research to support result in functional outcomes in the future. So there's research that supports if a child sits independently by the age of 2, a child who has CP, that they will walk in some way, shape, or form. It may look different, but they will walk. They may use a walker, they may use a gait trainer, but they will walk. So my job is also to give guidance in terms of that functional prognosis as well. And a child's needs change as their body changes. So what a 2-year-old needs is very different from what a 12-year-old needs. And those needs evolve as their body grows and changes. So that's sort of my role as a pediatric rehab doctor.
That's great. And Dr. Pham, I was going to ask, as far as, sorry, I just lost my train of thought. But what other types of diagnoses besides cerebral palsy are you treating? And how can you speak to a little bit to how do you keep the pediatrician involved in that whole process as you're going through a diagnosis or guiding a family through development?
Yeah, that's huge. So I treat a broad range of disorders. So the most common being CP, but I also work with kids who have TBI, traumatic brain injury, spinal cord injury, spina bifida, neuromuscular disorders like muscular dystrophies or myopathies. I work with kids who have concussion. I work with kids who have torticollis. Let's see, what else? Neurodegenerative disorders, neurogenetic disorders. And I think that might be all of them.
You had said toe walking before.
Toe walking. Oh, I can't forget toe walking. Yes, toe walking is really, really important. Yes, especially in this area where it seems like there are a lot of kids who toe walk, and there are, multiple reasons why children walk on their toes. So thank you, Dr. Shah, for reminding me of that. So we like to evaluate for the etiology or the cause of toe walking in addition to treatment for toe walking. And the involvement of the pediatrician is really, really important because we are a team for the care of your child. So collaboration with the therapist in the community, the rehab doctor, and the pediatrician. So we're all on the same page. We're all providing consistent recommendations is so valuable, because I find sometimes parents, families, children end up in the middle of different providers saying different things. So communication to me is very valuable. And so whenever I have a patient who's referred from a pediatrician, I will call that pediatrician and talk with them about what my thoughts are. I will send their note. I will tell them what workup I'm doing. I'll continue to follow through with them so that they have an idea of what's going on at my end, because that certainly relates to the overall health of a child.
And Dr. Shah, where do you feel like, you make that initial referral, whether it be to therapy or to a specialist, where does your continued care go from there? Do you feel like you're checking in at those well checks? Are there additional appointments that occur? How does that look on the pediatrician side?
Yeah, I guess it depends on the issue. So for something like, I think I send a lot of my kids who have torticollis, where I think it's like a congenital muscular torticollis and not from another cause, to you guys a lot of times, to Children's Therapy Center. And those I'm basically just kind of following up at their well visits. But I will say something that I think is really great from your practice, especially, is that I have, because you guys see them on a regular basis in between the visits that I'm seeing them, I've had several times have had somebody from your practice call with concerns about, whatever it is that you guys are seeing on your end, and just letting us know, hey, maybe you want to see this kid a little sooner because I noticed X, Y, or Z on this patient. And so that's a really great thing that I think a really great way that we can work together to help these families. Or something like, if I had something more like a pervasive developmental issue that was causing some issues with gross motor concerns, they may be, doing their PT program, but I might be seeing them more frequently to assess for other sorts of things like their speech or whatever it is that we're following. So I think it kind of depends on what the issue is, how often I see them. I think other things that we just sort of refer to PT or like even an early intervention, more of an early intervention program would be who's not maybe meeting milestones or doing as much catch up as we would expect. And then toe walking, I always find interesting because I think we had talked about this prior, where it's hard to even know necessarily where to go with it. And you had mentioned that to me, Dr. Pham, when we had spoken before about, we as pediatricians will sometimes refer the toe walker to ortho, and meanwhile, it's not really something that ortho is going to be interested in doing anything with, and it's much more suited towards a practice like yours.
Yeah.
I thought that was interesting, but yeah, I think we just see them on generally on their well visits because we're seeing them so frequently, but definitely more often if there's other red flags that kind of pop up while you guys are treating them.
Yeah, and even to just touch on, toe walking, since that is such a big area that we see from the physical therapy standpoint. I think the earlier our kids come in and we can intervene for something like that, and that really applies to a lot of the impairments that a child might be presenting with, whether it's like they're not crawling, they're presenting with the neck tilt early, they're tiptoe walking at an early age. early intervention is one route, but even with outpatient therapy, if we can intervene faster and bring in a specialist if needed, if progress isn't quite making, if we're not seeing the progress that we want to see, then ideally we can help resolve the issue sooner. For toe walking example, it becomes less habitual down the road. We can give them the interventions, the strength, like really focusing on their strength and alignment from the biomechanical side, address any, sensory concerns that might be contributing to their toe walking, and really try to help them get on the right track as they continue to age, because it does become more difficult to intervene. Same thing with torticollis. When they come to us at 6 to 9 months, it's much harder to impact because they're mobile. They don't want to be held still. They don't want to stretch. They want to move and explore. So when we can intervene earlier, it definitely makes a huge difference from the therapy standpoint.
Yeah. I think there's a big push in a lot of populations for earlier diagnosis. And I think the toe walking population is certainly one of them, in addition to kids with CP. And with toe walking, the thought is that kids learn to walk in this toe-toe pattern. And you have this just every time they're taking a step, they're sort of using the same pattern over and over and over and over again. And if you use that for 2 years versus using that for 8 years, that is a lot more difficult to retrain those motor patterns that your brain has learned. And so when kids are really little, it's a lot easier to retrain that pattern than it is in kids who are older. And in kids who have CP, there's a really big push in the CP community for early diagnosis, even diagnosis in the NICU, even if we're not 100% sure that it will actually be CP, we give the diagnosis that early because it will result in earlier intervention and theoretically change the trajectory of their functional outcome, which we've never thought of any sort of intervention as doing that in kids who have CP. But if you think about the stroke or TBI, traumatic brain injury research, most recovery of the brain happens within the first 6 to 12 months. So if you think about CP, this is a static injury to a developing brain. In the first 6 to 12 months, we need to be really doing everything that we possibly can. And in the olden days, like 5 years ago, people would not make that diagnosis until 2 years of age, which is very late. And so, if I have any sort of inkling that a child has CP, I will give them that diagnosis. The diagnosis does not require imaging. It's a clinical diagnosis. So it basically, CP is a static injury, meaning it doesn't change, to developing brain. So within about the first 2 years of life, we think, that results in some sort of motor dysfunction. So nowhere in there is there any MRI finding. So we don't even necessarily need that to diagnose CP and to move forward with treatment. And so there's this really, really huge push worldwide for earlier diagnosis in that population in particular.
So Dr. Pham, I do have a question. I know when a family is referred to a specialist, sometimes they Google, their brains go everywhere. They get very nervous that, oh, what does this mean for my child? So what does you've kind of trickled in a little bit about what you do during your exams. What does a specialty exam look like for these kids?
It's a great question. So it really depends on a child's age, right? So when a child comes in who's very young, we do a lot of history. So lots and lots of talking about birth history, developmental history, and then lots and lots of review of records. So oftentimes the child has already seen a physical therapist by the time they come to see me, because I get a lot of referrals from therapists. And so the therapist has already identified something of concern. And so I try to focus in on that as well. Is this something that the parent has identified as well as something that looks different to them? And then we do a full neurologic exam. And kids who are really little, you can't do formal manual muscle testing to see how strong they are, but there are other things that I can look at to see how strong they are. We can do some other neurologic type tests just to depending on how good they are at following directions. A lot of it is just watching what a child is doing, how they're playing with toys in their environment, how they're moving from a sitting to a standing position or a laying to a sitting position. And then once they're a little bit older, we get more of a hands-on physical exam in terms of their strength and in terms of their neurologic status. But a lot of what I also do is looking at range of motion, looking at flexibility, looking at some of those musculoskeletal things as well, because the brain controls your muscles, right, through your spinal cord, through your nerves, into your arms and your legs. And so when the brain is affected, we sometimes see results in the muscles. So evaluating the musculoskeletal system is also very important. And there are a lot of downstream effects from an injury to the brain on the musculoskeletal system. So it's really important to evaluate that as well. And that's the hands-on, moving their arms and legs and, looking at that flexibility, looking at their muscle tone, doing the reflexes, if you can get them to sit still long enough, things like that. And then after that, we have a long discussion about, what I found, what's concerning on the history and what our next steps are.
That's great. And I think it's important to note that, it's just because you've been given a referral to a specialist doesn't mean that there's something wrong. Yep. Sometimes it's just checking things off the box to make sure that we're on the right track, and that what the pediatrician might be identifying or what the therapist might be identifying is correct, and that we're moving in the right direction. Sometimes we just need that extra set of eyes to make sure that that we're guiding the family in the right way. And that's where those specialties can be so valuable.
Yeah, absolutely. I think a lot of those kids end up coming to me with gait differences. So gait and walking is something that I'm really passionate about. I love watching people walk and sort of breaking down their walking to figure out, why are they doing that? And a lot of that has to do with motor coordination and motor planning. And so if you're just sitting down and doing a neurologic exam and saying, how strong is this muscle? How strong is that muscle? You're not going to see how your brain actually coordinates those movements into a planned process, such as walking. So that's a really important part of it.
Yeah. And then, I know we were talking more about children with a known, developmental delay or some sort of injury at birth. What if my child is typically developing and they had some sort of injury, such as an orthopedic injury or traumatic injury, like a concussion? Dr. Shaw, how are you managing that? And then also Dr. Pham, how do you kind of get pulled into to assisting with those types of children?
I think for the concussion question, we do a lot of that in primary care world, simply because, we're usually, if they go to the emergency room because it was a more serious injury that involved either a loss of consciousness or need for a CT scan, they go there first, and then they are always told to follow up with us. So a lot of times we're also just seeing them without an ER visit, and they just have some continuing lingering concussion symptoms from even a more mild head injury. So we typically will clear them from those symptoms if they're kind of moving along a normal, typical trajectory and they're improving over time relatively quickly. If it's a case where it's either they're in some kind of heavy duty sports like football or something like that, we do use the concussion clinic to kind of help manage them. They do their own PT stuff, I think, with the concussion clinic. But I have actually never even thought to refer to a physiatrist for a concussion. So that's interesting that you do treat those, and be interesting to hear what kind of concussion patients you see.
Yeah.
Obviously it's the ones that are not the easy to clear ones that just go back to school and go back to sports easily. So
yeah. So, for that population, the population of kids who have concussion, obviously, we work very closely with the pediatricians in the community to make sure, because we know that you're going to be the first stop. after that ED visit or after it happens. Families are going to call and say, we need to get in because, my child fell and hit their head and they were vomiting, or, whatever the story is. We're concerned about concussion. So that initial treatment obviously is really important in terms of just a very short amount of rest and then getting back into activities. And then, if they're doing well, they're succeeding, they're advancing, they're getting better. And most kids do. The majority of kids who have concussion get better within about 3 to 4 weeks. Symptoms resolve and they get better and they are fully back into their activities. It's those kids who have symptoms beyond that point where I think we tend to intervene or step in as rehab docs. And depending on where you practice in the country, it's either a pediatric rehab doctor or a pediatric neurologist, or pediatric sports, in fact. So 3 different options. So I've worked with a lot of kids who've had sports injuries, but also non-sports injuries. And it's a different discussion, right? So returning back to play is a really very different discussion, especially in the context of multiple concussions. And there's a lot of emerging research over the last, 5 to 10 years on chronic traumatic encephalopathy. And so it sometimes there are some difficult conversations with, adolescents who want to go back to their sport. And, I often am the person who has to say, no, I don't think it's safe. Since you've had 6 concussions, I don't think it's safe for you to return to this sport because we don't know at this point what happens with repeated hits to your brain. We're learning about it and we're finding some scary things. So, that sometimes is a difficult discussion to be had. And that's sort of what we deal with is sort of the kids who aren't getting better quickly, the kids who have maybe multiple concussions, because we don't really know, at what point do you say, well, that's enough? We don't know. So I think that as rehab doctors, we work with a lot of children who have traumatic brain injuries of different types and different severities, concussion being on the very milder end of that. But because we see the sort of spectrum of traumatic brain injury, it sets us up to work very well with this population. So
we have an audience question that I wanted to get to before we wrap up here that I think sort of ties in really well with what we're talking about here. So we've mentioned making progress with maybe symptoms or an injury, but what about regression? What about going backwards?
Yeah. And Jason, is this in the setting of concussion, just in terms of the timing of the question?
Yes, I believe
okay.
so. It was a little earlier in the presentation, but I think it has multiple applications. Yeah.
Yeah. So I find that if kids return to activities too quickly, you can have sort of a regression in their symptoms. So say they're on a good track, their symptoms are getting better, and then maybe they overdo it and they do like 2 hours of soccer practice doing drills, and then they feel horrible. And, and then they're really struggling and, not able to participate in school. And I think for a lot of these kids, they sometimes will overdo it. And part of the reason is, honestly, a lot of these kids who I see who have more prolonged symptoms, these are the kids who are very high achieving, who really want to get back into school, who really want to get back into their sports, and they have a hard time taking it stepwise. They have a hard time taking it slowly because they don't want to be different. They want to do well in their classes. They want to, go to the next level for their sports, and so these are the toughest kids, I think, to work with because they're so motivated to get back. It's sometimes hard to say, let's take this a little bit slower. But oftentimes that's what happens with that sort of regression in symptoms in the recovery from concussion.
Even from a therapy standpoint, sometimes they'll, a child with post-concussive syndrome might come to us initially with PT because they might still be having, neck pain, migraines, headaches, just discomfort on that end. But then as we start to treat them and we start to see some of those musculoskeletal symptoms resolve, we start to kind of unearth some of the other issues they might be still having, like sensitivity to light or difficulty concentrating and focusing. And what's great being in a multidisciplinary environment is that we could pull in an occupational therapist, or we could pull in a speech therapist, and then we could start working more on some of those higher functioning, higher level stuff so that they can more easily transition back into school and sports and all that kind of stuff as well too.
I think with the concussion population, it's tough too, because it's not like something you can see, you know, like if you sprain your ankle, you have a big swollen ankle that's right there in your face. And as a pediatrician, when I see a kid who had a concussion, who has concussive symptoms, I try to really equate their head injury. Like I try to make it like make them understand that it's like any other part of your body. So if you had an ankle injury, really you do need to rest and stay out of your sport for, you know, an extended amount of time, because ankle injuries take a long time to heal. Similarly, you're trying to give your brain that rest. And Dr. Pham, you were mentioning we don't want to give it too much rest. We also want to get back into it slowly. So it's a dance between how much you can let them do versus pulling them back. So I feel like it makes it so much more trickier to deal with concussion, because it's not something that's as in your face.
Yeah, exactly. I think that's where a lot of kids struggle with school, because a lot of, I recommend to prevent the onset of symptoms to take breaks at school, but to raise your hand in a classroom and say, you know, I need to take a break, that looks different, and that can be hard to do. And so I think a lot of kids will just, oh, you know, I'm just not going to ask for that. Or sometimes the teacher will say, gosh, well, you look like you're just fine, you know, and you know, that's then hard for the child to the next time say, you know, I need to take a break, if you have a school system that's really not quite as supportive as they need to be.
I also did want to speak to kind of switching gears a little bit of when a parent might be seeing a regression in development. I know from a therapeutic standpoint, when a child's achieving their developmental milestones, sometimes we see what's called spiraling. So maybe they come in and they'll say, my child took a step today or 2 steps today. And then a week later, they say they went back to crawling and they aren't walking. Well, sometimes we see a child spiral backwards before they're on the cusp of achieving that new skill. So I always try to tell a family to, let's just watch it for a few weeks. Let's keep trying to promote and move them in the right direction and see if they start to progress and make that progress. So that regression that you might be seeing might just be that they're getting ready to kind of jump to that next skill, and they just need that little extra practice and confidence. Same thing with torticollis. You know, as a child's learning how to sit or learning how to crawl, we might have resolved their head tilt and they're nice and straight, but as they achieve this new skill, we start to see their tilt come back. And I always tell parents, give it like 2 weeks. If it stays persistent after 2 weeks, you know, then we need to go back to the drawing board and really start to, you know, pick up our stretches again, pick up our strengthening exercises again. But let's see if they're just gaining confidence in this new position, and then we'll see them continue to make progress down the road too.
Mm-hmm.
Jason, did we have any other questions?
That was it for all of our audience questions.
Well, thank you, Dr. Shaw and Dr. Pham. Was there anything else that you wanted to mention on our call today?
No, thanks for this opportunity. It was great to kind of talk through how we all work together for different patient populations. So
yeah.
I definitely learned a lot as well, just about how we can integrate, Dr. Pham, your specialty, into all of these things that we're seeing. So this has been great.
Great. Yeah. And I definitely think, I hope today families walk away knowing that specialties aren't so scary, and that, you know, really, we're just really trying to work as a team between the therapist, the pediatrician, and our specialists to really help your child get to where they want to be and where you would like them to be as well too. So thank you for joining us, everyone.
thank you, everyone.
Thank you. Thank you.